Cancer of the oral cavity. Introduction. The oral cavity is one of the most complex, anatomically dense region in the body, and it is responsible for clinical functions such as speech, articulation, swallowing, facial expression. And confines of the oral cavity starts with the lips anteriorly and posteriorly, with the plane going through soft hard palate junction, circumvallate papilla, hyoid bone. The subsides of the oral cavity include the lips, alveolar ridge, floor of mouth, anterior tongue, anterior two-thirds of the tongue, hard palate, retromolar trigone, and the buccal mucosa, and anterior tonsillar pillar such as sulcus terminalis, and the boundary of the soft palate where the oral cavity stops and the oropharynx begins. Cancer of the oral cavity are the 10th most common cancer in the man and 15th most common cancer in women worldwide. In United States, they are twice as common in men than in women, and the most common head and neck cancer in the US is oral cavity, accounting for 38% of all upper aerodigestive tract malignancy, and of this 32% occur in tongue and 20% occur in the floor of mouth. The incidence in this specific mortality or oral cancer has declined by 1% and 1.3% respectively since 1975, and this is likely a reflection of a decline in the tobacco use. Although the incidence of oral cavity cancer amongst races is relatively equal, and the mortality of African American is twice than in whites, and the average age at diagnosis is 60 years, incidence in patients less than 40 years has been slowly increasing. The structures within the oral cavity are composed of diverse tissue including the muscle, bone, mucosa, teeth, salivary glands, taste epithelium, and owing to the variety of this tissue in the oral cavity, a wide area of possible tumors can arise, and despite this 95% of the oral tumors are squamous cell carcinoma and 5% are the salivary gland tumors, sarcoma, lymphoma, mucosal melanoma, dentigerous tumors, distant mets, as well as nerve sheath tumor. Risk factor. The strongest etiological habit in the development of oral cancer is the use of tobacco products in conjunction with the alcohol consumption, and the risk increases in a dose dependent manner. 1.5 fold increase in the light smokers, like 10 cigarettes per day, and 4 fold increase in the heavy smoker, like 30 cigarettes per day. And the risk is also increased over time with those smoking more than 20 years, having 44 increased risk of developing oral cancer, and the same patterns are observed with alcohol consumption across all types of alcoholic beverages. Chewing tobacco, that is snuff, comes with a 4-fold increased risk of the oral cancer, and similar substances such as mixture of tobacco with areca nut and betel leaf, betel nut quid, they are also culprit of oral cancer, and especially those of the buccal mucosa, and this practice is most common in India and Southeast Asia. Lastly, reverse smoking is where a lit end of the cigarette is placed in the mouth during inhalation. 47-fold increased risk of heart palate cancer is the most common woman in India. While the HPV is known cause of separate entity of the oropharyngeal cancer with far improved prognosis, the same is true for oral cavity. 15 to 25% of the oral cancers can be associated with the HPV, but their survival are equivalent to their non-HPV counterparts. Chronic dental disease may lead to some oral cancers, namely those of the alveolar ridge, lateral tongue, and buccal mucosa. Chronic dental disease may lead to some oral cancer, alveolar ridge, lateral tongue, buccal mucosa, and they are most commonly seen in female non-smoker, non-drinkers. And this chronic inflammatory condition such as lichen planus can be a precursor of oral cancer, and however a malignant transformation is seen in less than 2%. Presentation of the oral cavity cancer is directly related to the site of the cancer, and the typical symptoms will include painful mass, lump in the or ulcer, non-healing ulcer, bleeding, dysphagia, dysphonia, trismus, halitosis, neck mass, loose teeth, and referrotalgia. All patients will need a thorough physical examination, flexible laryngoscopy to evaluate the airway for disease extent, secondary primary tumors, airway compromise, Biopsy of the lesion is needed and is typically performed in a clinic. Imaging is then obtained and must lead to a oral cavity, neck and chest. Common imaging modality is the CT of the maxillofacial area, neck, chest with contrast, and full body PET scan with a diagnosis of the CT. MRI is reserved in cases where the dental artifact obscures the view on CT, and when the perineural invasion is present, or when the bone invasion is present, and the extent of marrow involvement needs to be determined for treatment planning. So indications of MRI in case of dental artifact, perineural invasion, bone marrow involvement, for the treatment bone invasion. Once the workup is complete, it is strongly recommended that each case be reviewed at a multidisciplinary tumor board, and the board should consist of head and neck surgeon, radiation oncologist, medical oncologist, radiologist, pathologist. Ideally, if ancillary staff such as dentist, speech language pathologist, dietitian, physical therapist are also present, and each case is presented. All of the clinical data are reviewed to provide a clinical stage and consensus treatment recommendation, and the patient can then be counseled on all of their options as well as team recommendations. And the AGCC staging system is used for staging oral cancers and was updated on to version 8 in 2018. Now, treatment approach to each subsite is considered treatment of the oral primary tumor as well as treatment of the neck, like lymphatic drainage, and the vast majority of the oral cancer is best treated with primary surgery, and then radiation therapy is typically used as an adjuvant, and chemotherapy in conjunction with the radiotherapy. So lip is the one of the most common head and neck cancers, especially in the areas where and sun exposure such as South US and Australia, and it is rare in Asian and blacks. And a stereotypical patient is a person with light colored skin who works and plays in a sun with little guard of the sunscreen of the skin coverage, and the most males in 60s and 70s, while most lip caused by sun exposure and also results of chewing tobacco and pipe tobacco from the tobacco, chronic pipe hit, irritation, chronic dental disease, alcohol consumption, and smoking. And more than 90% of the lip cancers, they are squamous cell carcinoma, and more commonly found in the lower lip. And the second most common lip cancer is the basal cell carcinoma, which is most commonly frequent in the lower lip. Leukoplakia, carcinoma in situ, they are common problems of the lower lip and may precedes the appearance of carcinoma by many years, and primary lesion arising from moist mucosa of the lip considered under the section of the buccal mucosa. The lips are composed of orbicularis oris muscle, which forms the sphincter with the skin on the external surface and mucous membrane on the internal surface, and the transition from the skin to mucous membrane is vermilion border. And blood supply is from the branches of the facial artery, the superior and inferior labial arteries, along with the respective labial and facial veins, and these vessels form a robust circumferential arcade, which then should kept in mind when the performing lip resection with concurrent neck dissection or local flaps for lip reconstruction. The motor nerves are branches of facial nerve, that is cranial nerve 7, and the sensory nerves to the upper lip is infraorbital branch of the 5th cranial nerve, and the mental nerve V3 supplies the lower lip. Infraorbital branch of trigeminal nerve and mental nerve, this supplies, so infraorbital supplies upper lip and mental nerve supplies the lower lip. And the lymphatic drainage of the lip include level 1 to 3. Upper lip also drains the preauricular and infraparotid perifacial upper level 1b. One major difference between the upper and lower lip lymphatic drainage is that the upper lip only drains to the ipsilateral side, while the lower lip drains bilaterally, and this is due to embryologic fusion plane of the central frontonasal process, which separates the left and right lymphovascular channel. And the mandibular process fusion, however, allows for the lower lip channels to cross midline. Multiple muscles insert on the lateral deep surface of the orbicularis oris muscle and thus contributing to the myriad of complex oral movements. And because the lips are of critical importance of cosmesis, facial expression, oral competence, speech and swallowing function, it is imperative that treatment goals include a balance between cure and aesthetic and functional morbidity. Pattern of spread lips cancer can originate from the skin of the lip to the vermilion and may invade the adjacent skin and orbicularis oris muscle. Advanced lesion invade the commissure of the lip, buccal mucosa, mandible, eventually the mental nerve. So perineural invasion occurs in 2% of the cases reported by buyers and co-workers. Was related to the recurrent lesion, large size, mandibular invasion, a poorly differentiated histology. So lymphatic spread is almost unheard of with BCC, but with squamous cell carcinoma is found in 5% of the cases, and this is the risk is of for nodal increased by high grade histology, large lesions, invasion of the buccal mucosa of the lip, and patients with the recurrent disease. So clinical picture is squamous cell carcinoma may present enhancing discrete lesion that is not tender until it ulcerates, and some lesions develop slowly on a background of leukoplakia CIS and present as a superficially ulcer and lesion with little or no bulk. Erythema of the adjacent skin suggests dermal lymphatic invasion, and palpation of the lip will reveal extent of the induration, and paresthesia of the skin of the lower lip indicates perineural invasion. So section of treatment modality, early lesions cured equally well with the surgery or radiotherapy, and surgical excision is preferred for majority of the lower lip lesion up to 2 cm in diameter that do not invade the commissure. Treatment is simple, cosmetic results excellent. Removal of more than the lip with simple closure usually results in a poor cosmesis and functional results, and therefore require advanced reconstructive procedures such as local flaps. RT is a viable option for lesion involving commissure for lesion over 2 cm in length and upper lip carcinoma. Advanced lesion with bone, nerve and node involvement frequently require extirpative surgery and neck dissection and reconstruction and adjourn RT. The regional lymphatics are not treated electively for T1 cases. The T2 cases elective neck dissection treatment is encouraged, but the option in reliable patients who can be actively surveyed. An advanced lesion like high grade lesion, recurrent lesion, elective neck dissection need elective neck treatment, and clinically positive nodes are managed as previously discussed. Surgical treatment for early lesion 0.5 to 2 cm may only require partial thickness resection with local flaps or full thickness wedge excision with the primary closure of in a V or W shape. And if a vermilory is diffusely involved with a little or no involvement of the muscle, vermilectomy may be performed and the mucosa from the labial, vestibule or of the oral cavity advanced to cover the defect. And as the size of the defect increases, more sophisticated regional flaps or free tissue transfer are needed to reconstruct the defect. And in an advanced lesion, concurrent neck dissection including level 1 to 3 are performed. Irradiation techniques, external beam, RT, brachy, combination of both, and in brachytherapy accomplished with the removal of source of the iridium 192. EBRT 55 to 63 gray 1.8 gray per fraction, or electrons that is 60 to 70 gray at 2 per fraction, shield behind the lip to limit the exit external beam RT. And IMRT is not indicated except for occasional patients with advanced neck disease, clinical PNI, where it is necessary to extend the dose distribution to skull base and reduce the dose to the contralateral parotid. For more advanced lesion, combination of chemo external beam artery is appropriate. McKay and Sellers reviewed 2000 patients of all stages of lip cancer in whom 92% were managed with the initially RT. Primary lesion was controlled by the initial RT in 84% of the cases, and additional 8 patients were required salvage by the treatment for overall local control of 92%. And of who presented with the clinically involved nodes, 58% had control of the disease, but only 35% had control of the disease when neck nodes were appeared later. 5-year cause specific survival was 89% and absolute survival 65%. Moose and Snow reported the result of 1400 patients treated with a microscopically controlled surgery for squamous cell carcinoma of the lower lip between 1936 to 1976, and early 83% had less than 3 centimeter in diameter with a 5-year cure rate of 96%, and for 192 patients with the cancer that measured 2 centimeter or more, the cure rate dropped to 60%. Oral competence, which permits treatment to control oral secretions and effectively suck, blow, then speak, swallow, requires sphincter function of an intact orbicularis oris muscle. Hence, disruption of the sphincter function resulting from division of the orbicularis oris should be restored. Microstomia, drooling, secondary to oral incompetence, may occur after a large resection, and if the oral opening is too small, patients may not be able to insert a denture, and there will be some atrophy and fibrosis of the irradiated tissue, and this worsens with time, and as years go on, this effects can result in poor dental function, oral function, and some soft tissue necrosis, osteoradionecrosis may occur, and these problems is together.